This program is brought to you by Emory University.
Good morning, everyone. Happy Friday. Welcome to the Friday's Fellow Conference. This morning we have Nishant Vatsa, who is one of our academic clinical investigator research track fellows who's in his first year of clinical fellowship. Nishant is from New Jersey originally. He went to Rutgers for medical school and then Emory for residency, and we were lucky to keep him on as a cardiology fellow. And he will be talking to us today about adult primary cardiac tumors.
Thank
Go
you so
ahead.
much, Dr. Coley. So as titled my presentation today, I'm going to present as Mass Effect, adult primary cardiac tumors. I have no disclosures. My objectives are pretty simple this morning. I really want to review common adult primary malignant tumors, which you can see are very exceedingly rare. So I think it's always good to review these types of disease processes. And also review the more common adult primary benign tumors that we would likely see in our clinical practice, and is always good to go through. But I'll first start out with a case, and this is a case of chest pain and syncope. So this patient actually presented to Emory Midtown last month, and she was a 48-year-old woman with the past medical history of hypertension and no other cardiac history, who presented with syncope and chest discomfort. The syncope actually happened at work. She's a teacher, and while the patient was standing up while her class was at recess, the patient felt abdominal discomfort that migrated to the chest, and that was described as a heaviness. She then had associated lightheadedness, warmth, diaphoresis, and nausea. And because of these symptoms, the patient kind of sat on her desk, and her aide noted that the patient lost consciousness, although the patient does not remember this. As a result, the aide called EMS, and on arrival, EMS found the patient to be hypotensive with systolic pressures in the 60s. And en route to the hospital, the patient's blood pressure responded well to fluids. And on arrival, she denied a history of recent chest pain, pre-syncope, dyspnea, or illness outside of the events that happened that day. Because of the low blood pressure, the ER physician was promptly called to bedside, and they performed a POCUS, or a point of care ultrasound. And their point of care ultrasound, actually, they noted what they were concerned about was tamponade physiology as well as moderate pericardial effusion. And so they promptly ordered a stat echo, consulted cardiology. And because the patient had syncope, they also ordered CT imaging, a CTPE, to rule out any PE that may have caused the syncope. And so the labs that she had were pretty non-significant, and her vitals, she was borderline tachycardia in the high 90s, low 100s. Her EKG was pretty unremarkable, except for some T-wave inversions in 3 and AVF, subtle T-wave inversions. Unclear if these were new or old, because the patient really hadn't interacted with our medical system before, so we didn't have any prior EKGs. Now for the interesting images, the stat echo revealed this. This was the peristernal long view, and as you can see here, there was a moderate-sized effusion with some diastolic collapse of the right ventricle. This is also demonstrated in the peristernal short axis view at the level of the aortic valve. And then you could really see it here in the subcostal view, where there's a moderate-sized pericardial effusion that is more prominent in the apex, and there's some diastolic collapse of the right ventricle. Here's a 4-chamber view, and the reason why I put this in, you can't really see the diastolic collapse as much, but if you look closely, and it may be hard to pick up, there seems to be increased echogenicity at the junction of the right atria, and where they possibly meet the pericardium, where the vena cava kind of enter in. And so I thought that was pretty interesting. Now, the CT scan, and this was the IVC, which was pretty plump, and it was non-collapsible, kind of, consistent with tamponade physiology. Sorry. The CT imaging was pretty concerning as well, but not for the reasons that the radiologist read or what the ER physician kind of thought they were going for. So I'll kind of scroll through this imaging, and as you can see, there seems to be a mass in the right atrium that kind of adheres to the pericardium. Additionally, there seems to be a kind of high intensity pericardial effusion. Interestingly enough, the radiologist didn't even call out this right atrial mass. All they kind of mentioned was that There's moderate intensity pericardial effusion that might be suggestive of a bloody pericardial effusion, and that there was a contrast reflux into the hepatic vein, suggestive of elevated right-sided pressures. So this mass that was seen was kind of missed by the radiologist, which I thought was pretty interesting. In any case, the patient was immediately cardiology, after consultation cardiology, it was thought that tamponade was the most likely cause of the patient's presentation. And so she was emergently put to the cath lab where a pericardiocentesis was attempted. However, per the op report, the pericardiocentesis was aborted because they couldn't advance the needle into the pericardial space because of how small the pocket was. And so, since the patient was relatively stable, they sent the patient for close monitoring into the CCU. And a repeat echocardiogram the next day, about 18 hours after presentation, showed, interestingly enough, resolution of the effusion. And it's kind of a mystery as to why the effusion disappeared. However, going through the chart and the notes, the prevailing theory is that perhaps the effusion kind of drained into the pleura after the attempted pericardiocentesis, that maybe there was a tract that was made from the pericardium to the pleura from the pericardiocentesis. But the patient continued to have pleuritic chest pain. And since there was concern of a pericardial etiology, the primary team decided to get a CMR to kind of further characterize the pericardium to see if there was any inflammation going on. And here is the images from the CMR. And here you could distinctly see a right atrial mass that kind of adheres to the pericardium. And the official MRI read was, there is a large irregular mass along the entire right atrial free wall, measuring 4.8 by 2.8 centimeters, penetrating the opposing pericardium and extending toward the SVC-RA junction. There does not appear to be involvement of the tricuspid valve. The mass enhances with first pass perfusion, suggestive of high vascularity. There's heterogeneous late gadolinium enhancement within the mass. These constellation of findings are suggestive of a malignant mass, such as angiosarcoma, lymphoma, and metastatic disease. And I think this is a good segue to what I'm going to talk about, because we're going to focus on angiosarcoma and lymphoma as kind of one of the more common primary malignant cardiac tumors. Unfortunately, the rest of the case for this patient was uneventful. After these findings, it was suggested that oncology and CT surgery be brought on board, and they were consulted, and they recommended a cath, a PET, and a possible resection. Unfortunately, the patient, this is kind of a devastating diagnosis, and the patient left because she wanted to seek second opinion. And as of my chart review earlier this week, the patient hasn't followed up at Emory Midtown or elsewhere in the Atlanta area as of yet. However, this is a case that's only a couple of weeks old, so hopefully she follows up. And so that brings me to adult cardiac tumors. Adult cardiac tumors are actually not uncommon. In a large autopsy series out of Italy, which autopsied 1,900 patients with primary cancer, they found about 8.6% of those patients actually had cardiac involvement. But the cardiac involvement, the vast majority of that cardiac involvement was just metastasis from tumors elsewhere. So these tumors were secondary. This was further confirmed by data studies that leverage data from the Surveillance Epidemiological and End Result Data Registry, which is a registry that kind of collects cancer data from 18 registries across the United States, Atlanta being one of those registries. And there, out of 100,000 cardiac tumors, what they found was that actually 99.2% of them were secondary to some other cancer. So only about 0.8% of all cardiac tumors are primary. And so other studies, a large autopsy series, data from large autopsy series have estimated that the prevalence of primary cardiac tumors to be only about 0.02%. So these tumors are exceedingly, exceedingly rare. And I want to go through some kind of general trends when thinking about these tumors before I go into the specific tumors. And the first one of which is the clinical manifestations for which we might see these patients present. And the prevailing, theme about the clinical presentation about these tumors is that location determines how they present. These tumors can cause obstruction of blood flow, so they can cause heart failure symptoms. They can cause infiltration of the myocardium or coronary arteries, so they could cause arrhythmias and conduction abnormalities. They can cause also ACS if they infiltrate the coronaries. Additionally, these tumors have a predilection to embolize, and so they can cause pulmonary emboli and systemic emboli. So as you'll see, certain tumors have a predilection to certain areas of the heart, and so tumors that are in the right atrium or the right ventricle, as you might suspect, would cause right-sided heart failure symptoms like hepatomegaly, ascites, elevated JVD. Additionally, they may cause pulmonary emboli. Tumors that are on the left side of the heart would cause more left-sided heart failure symptoms, such as pulmonary edema, orthopnea, PND. Additionally, infiltration they can cause of the left ventricle myocardium, they can cause conduction abnormalities, arrhythmias, and their emboli, highly concerning, can also cause strokes. Often these tumors also extend to the pericardium, like we saw in our patient before, and so they could cause pericardial effusions, tamponade, and also some of these tumors have been associated with general constitutional symptoms like fatigue, fever, and weight loss. So these are kind of the clinical syndromes that, symptoms that, these tumors present with. And what makes it difficult diagnosing is that none of these symptoms are kind of specific and can be caused by a whole litany of other diagnoses that are more common. Diagnostics of these tumors are pretty consistent and largely centered around multimodality imaging. Echocardiograms are often, in review of a lot of case reports, echocardiograms are often the inciting test that causes workup for these tumors. And that's because echocardiograms are so readily available and we use them so much, they're so cheap. We use them to diagnose a litany of other cardiac conditions. So often these patients are worked up after an echocardiogram revealing a mass that is seen on the echo itself or concerning complications of a tumor, like we saw in our patient, such as a pericardial effusion. CMR is probably the best test, non-invasive test to be used in diagnosing or helping diagnose these tumors. And that's because this imaging modality has a high resolution of soft tissue masses. So it really allows for better distinction between, benign and malignant masses, and also, defining whether these masses are thrombi or they're tumors or not. So these are incredibly useful imaging modalities. Unfortunately, they're not as readily available as echocardiograms, and they're pretty expensive. And the imaging time is more involved for the patient. CTs, like we saw in our case, can also be used, and kind of like echocardiograms, CTs are so readily available and we use them so much, especially in the ER. So a lot of these cases, the workup was incited by an abnormal finding on CT, as we saw in the case before. And CTs are especially useful when CMR is not readily available. It gives a good representation of the location of the mass and how big the mass is. PET scans, like in other cancers, can also be used. You could see focal uptake of the cancer in the myocardium. And also you could see uptake elsewhere in the body that would be suggestive of metastasis. And PET scans, I think, are useful because if you see uptake in the heart, yet you see uptake elsewhere in the body that is considered malignancy, most likely the uptake you're seeing in the heart is likely secondary based on the prevalence that I just mentioned. So it may be useful in identifying extracardiac manifestations, also being a useful tool in identifying whether this is a primary cardiac process or this is a secondary cardiac tumor. Finally, coronary angiography is often utilized as a workup, as our CT surgery colleagues kind of recommended in the case that I presented earlier. And the benefit of coronary angiography is that it really evaluates the blood supply of these epicardial masses, which is crucial in surgical planning. It helps the surgeon determine one, how resectable the mass is, whether they can completely resect it or not, and number two, whether they need to resect other crucial structures like coronary arteries and graft those arteries. And finally, the gold standard, like in other cancers, is biopsy. And for discrete tumors, as you'll see, and I'll go further into later on, complete resection is kind of the diagnostic approach because this could also be potentially therapeutic. However, there are certain tumors that are diffuse and unresectable, And at that time, you can consider percutaneous biopsy with the risk of actually seeding the tumor elsewhere in the body. And so there should be caution when using percutaneous biopsy, and you should really only utilize them if you think it's going to change your management, such as if the histology of the tumor might guide you from surgery more towards chemotherapy. And with that, I'll go into specific tumors and start out with primary cardiac malignant tumors. And as I mentioned before, primary cardiac tumors are exceedingly rare, about 0.02% of the population. Case series and autopsy series have suggested that 25% of these 0.02% are malignant. So the vast majority of these primary cardiac tumors are not even malignant; they're benign. Data from SEER actually confirms this, and it suggests they looked at cancers, all cancers in general, and only about 0.008% of all cancers were malignant tumors, primary cardiac malignant tumors. And I think this is good, and it's kind of good news because, as you'll see, these tumors are a devastating diagnosis, and the prognosis is very, very poor. And so going through some of the different types of primary malignant cardiac tumors. So the most common one, which is cited to be about 30 to 45% of all malignant tumors, is angiosarcoma. And there's a picture on the left showing how vascular these tumors really are. And they're so vascular because these tumors arise from the endothelium of blood vessels. They're the most common primary cardiac malignant tumor. And they actually have a predilection of the right atrium and the AV group, and they can often extend to the pericardium. And that's kind of what we saw in our patient before. And what likely happened in our patient before is actually a common finding in angiosarcomas, is that they cause a bloody pericardial effusion with negative cytology. These tumors are very aggressive, and they actually have a very, very bad poor prognosis, which I'll go into later. The second most common, sarcoma of the heart, primary sarcoma of the heart, would be leiomyosarcomas, and these are, as the image on the left portrays, are spindle cell high-grade tumors that arise from smooth muscle cells. And they actually have a predilection of occurring in the left atrium. And because these tumors are so aggressive, they often invade the mitral valve. So they cause those left-sided obstruction symptoms that I mentioned earlier. And they can also infiltrate the pulmonary veins. So again, causing kind of left-sided heart failure symptoms. Because they're so aggressive, unfortunately, even after surgical resection, these cancers have a high chance of recurrence. Now, getting a little bit away from sarcoma for a moment, lymphomas are another. Primary lymphomas of the heart are also not uncommon. Case series and retrospective cohort series have estimated that primary lymphomas comprise about 10 to 25% of all primary cardiac malignant tumors. And these lymphomas are predominantly diffuse B-cell lymphomas. And they could really occur anywhere, but based on case series and retrospective cohort studies, they also have a predilection of right-sided chambers, particularly of the right atrium. And they often occur in individuals who are immunosuppressed. So it's been found that those who have HIV or transplant patients who are taking immunosuppressants are particularly prone to these types of lymphomas. Now, again, these lymphomas are comprised of a very, very small proportion of the total lymphomas that happen in the body, about 0.03%. However, when they do occur, they do generally have a worse prognosis than extracardiac lymphomas, with a mean survival time of 24 months. So it's exceedingly rare, which is kind of the theme of the primary cardiac malignant tumors, but it is a devastating diagnosis with a horrible prognosis. Rhabdomyosarcoma are sarcomas that arise from the striated muscles, from the muscle cells of the heart, and they can occur anywhere in the heart. And so they could occur in the ventricles, the right ventricle, left ventricle, and they can grow into the cavity itself, causing obstruction symptoms. And they can also involve the pericardium. Osteosarcomas are exceedingly rare, but I thought they were pretty interesting because they arise from bone cells and they have a predilection for the left atrium. So quite often these tumors will present as a calcified mass in the left atrium. And then finally, mesotheliomas you could have primary mesotheliomas of the heart, exceedingly rare again. They only make up about 0.3% of all mesotheliomas. And they often involve, like as this picture shows, the pericardium. And because they involve the pericardium, they often present with tamponade or constriction. But there have been case reports of mesothelioma of the AV node causing conduction blocks. And unlike their counterparts in the lung or the pleura, these actually have a worse prognosis, and the median survival time of these mesotheliomas are about 2 months. Now, getting more into the prevalence of these types of tumors, this is the figure I showed you earlier. So in general, these tumors are very, very rare. They comprise about 0.008% of all all tumors in general. And in past decades, the incidence of these tumors has actually been rising. If you look at the 3 bars on the right, from the 1973 to 2011, this is data from actually SEER, the incidence per 100 million of these primary cardiac malignant tumors has been increasing. And it's thought to be that it's increasing because we're getting better with imaging. We're getting better with the echocardiograms. We're using them those more readily. We're using CMR and things of that sort. And this uptrend has been primarily driven by an increase in incidence or diagnoses of lymphoma and sarcoma. Well, you can see here in the bar graph, the incidence of mesothelioma has actually been decreasing. And, it's thought to be because we're using less asbestos in the environment. So these mesotheliomas, they have an association with asbestos like their pleural counterparts as well. Now for the prognosis of these tumors, and as I kind of alluded to earlier, these tumors rapidly proliferate, and so they infiltrate a lot of cardiac structures. They have a high tendency to metastasize, and all this kind of creates a milieu of very, very bad prognosis. And this is actually data from SEER as well. As you can see in the Kaplan-Meier curve on the right, the survival of lymphoma, sarcomas, and mesotheliomas are abysmal. Case series have suggested that the median survival of those diagnosed with primary cardiac malignant tumors to be between 6 and 14 months. The overall 1, 3, and 5-year survival is 46%, 22%, 17% respectively. Sarcomas, those who have sarcomas do a little bit worse than those who have lymphomas. With those who have sarcomas have a 1 to 3, 5 survival rate of 47, 16%, and 11%. Those with lymphomas have a survival of 1, 3, and 5-year survival of 59, 41, 34%. So still bad, but not as bad as sarcomas. So again, just to reiterate, these are pretty devastating diagnoses. And that portend a very, very short survival time and high mortality rate. And, there's been a lot of case series and retrospective studies to kind of find out what determines a bad prognosis. And as you may imagine, those who have metastasis or their histology shows high mitosis at diagnosis, those individuals tend to do worse than other individuals. Additionally, there has been some association with the tumor subtype and mortality, particularly angiosarcoma portends a worse prognosis than other tumor subtypes. So the tumor subtype and whether the cancer is spread or the potential of the cancer spreading really determines the prognosis of the patient. The other thing that has kind of portended the prognosis of the patient that's been seen is whether or not the patient has received treatment, which kind of makes sense. And this is data from the National Cancer Database, which looked at about 747 patients that had primary cardiac malignant tumors. And as you can see pretty nicely here, those who had surgery did better than those who did not have surgery. At 1 year, those who had surgery had a survival of about 53%, so still bad, but better than those without surgery who had a survival at 1 year about 23%. And not only whether the presence of treatment is important for prognosis, but how well the treatment was. So how well the surgery did also actually influence prognosis. So those who had a complete resection did significantly better than those who had microscopic residual disease and macroscopic residual disease after surgery. So this is also data from the National Cancer database. And what you can find here is that the survival rate at 1 year of those who had a complete resection was about north of 60%, about 61%, while those who had some microscopic residual disease had a 1 year survival of about 51%, and those who had macroscopic residual disease, so disease you could actually see, had a survival at 1 year of about 27%. So really how good the surgeon did really influences survival as well. So surgery is a mainstay of therapy for primary cardiac malignant tumors. And these outcomes are heavily influenced by the surgical results. So complete versus incomplete resection. And, there's other case series and retrospective cohort studies that kind of outline this as well. I think there's a case series from Mayo. I mean, it was about 32 patients or so that showed that complete resection, individuals with complete resection in these diagnoses lived for had a median survival of about 17 months. And those who did not have a complete resection, had an incomplete resection, only lived about 5 months. There was another study that leveraged data from a registry in Canada that showed that those who had complete resection lived for had a median survival about 25 months. And those who didn't have a complete resection had a median survival about 5 months. So really, complete resection is not only diagnostic, but it's kind of the best therapeutic option that we currently have. There's an unclear benefit of adjuvant chemotherapy and radiation therapy. Data is really sparse here. Unlike other cancers, there's really no randomized controlled trials that kind of compares certain chemotherapy regimens and sees how well they do with primary cardiac malignant tumors. And that's probably because these tumors are exceedingly rare. So it'd be incredibly hard to enroll for a trial like that. But there is some retrospective cohort data, particularly out of the study I just mentioned that utilized the National Cancer Database. And essentially what they found was that there might be a survival benefit in those with stage 3 cancer. So they compared those who had chemotherapy and radiation therapy on top of surgery to those who had surgery alone. What they found was that at 1 year, those who had adjuvant chemotherapy or radiation therapy had a survival of north of 60% at 12 months, whereas those who had surgery alone had a survival of 17%. That was among those with stage 3 cancer, so pretty advanced. They didn't find a survival benefit in those with stage 1, 2, or 4 cancers, but it's with this caveat, the N was very, very low, as you might imagine. So perhaps the subgroup analysis wasn't powered enough to detect differences amongst these two treatment modalities. Systemic therapies like chemotherapy and radiation therapy, though, they may have a larger role in lymphomas versus sarcomas, which are more solid and kind of discrete tumors. In one case series out of Japan, out of 40 individuals who had primary cardiac lymphoma, actually an anthracycline-based therapy regimen, actually about 38% or 15 individuals out of those 40 actually achieved remission. So there might be some role there, but again, the benefit of these chemo and radiation therapies are unclear because there's really a paucity of evidence showing their clear benefit. And finally, cardiac transplantation there has been case series investing cardiac transplantation in these individuals. There was one case series I saw out of Houston Methodist, which analyzed 21 patients who had a diagnosis of primary cardiac malignant tumor, and they had cardiac transplantation. And actually, interestingly enough, 7 individuals of those 21 were cancer-free at 27 months. So it's a pretty aggressive therapy, but with, again, unclear benefit. But according to that case series, it really helped those 7 individuals. Now, how are we doing with primary cardiac malignant tumors as the decades have rolled on and as our imaging techniques have improved, our surgical techniques improved, and our chemotherapy has improved? So, this is data from SEER. And as you can see, that the survival has statistically increased. There's a statistically significant increase in survival in those who were diagnosed and treated from 2000 to 2011 versus those who were treated in the 90s, 80s, and 70s. And although this reached statistical significance, I mean, if you could just see from this graph, the improvement is actually kind of marginal. So we're actually still doing pretty bad in treating these patients. And that's likely due to the late presentation of these patients and how aggressive these tumors are. But the slight increase in survival is likely due to, our more multimodality imaging being more readily available, and probably is largely due to improvements in lymphoma therapies. So we might be better at treating primary cardiac lymphomas, but not necessarily sarcomas. So still a devastating prognosis in this current day and age. Now going into a more lighter topic, primary cardiac benign tumors luckily have a better prognosis. And I'm bringing this pie chart back because luckily most primary cardiac tumors are benign, about 75% of which are benign. And these are largely made up of myxomas, which have a predilection to the right atrium. They normally grow into intra-atrial septum, and it's a pedunculated stalk that extends into the left atrium. You also have papillary fibroblastoma. So these are the two most common benign tumors, with myxoma being the most common and papillary fibroblastoma the second most common. And papillary fibroblastomas, they have a predilection to the valves, left side greater than right side. And the other common adult benign tumors would be fibromas and lymphomas, which have a predilection to the ventricular walls. Now, getting into myxomas, myxomas are scattered. Microscopically, myxomas look like scattered cells with a mucopolysaccharide stoma, and they're derived from multipotent mesenchymal cells. And grossly, they kind of almost look like a stalk of grapes if you look at the image on the right. They appear as a pedunculated mass with a smooth fibril or villous surface attached to the interatrial septum and often extends into the left atrium. About 80% of myxomas are found in the left atrium. And because they're found in the left atrium, as you can imagine, they cause obstruction of blood flow through the left atrium, also obstruction of the mitral valve. They could kind of extend through the mitral valve and cause that kind of tumor plop that we're so often tested upon on boards, as you can see in the echo image on the right. So obstruction is a very common symptom of these tumors. These tumors can actually also cause embolization. In a case series of 112 patients in France, actually 30% of these patients who had myxoma had some sort of systemic embolization, like stroke. And it's thought to be because myxomas with the friable or villous surface can kind of, cause either the tumor itself can break off or, thrombi can form on top of the tumor, which can embolize. And about 35% of these tumors actually have a fibril or villous surface, so there is some embolization risk with these tumors. Interestingly enough, these tumors have been associated with constitutional symptoms like fevers and fatigue, and that's thought to be due to the cytokine production of these tumors. It's thought that these tumors actually produce IL-6, which can kind of cause these constitutional symptoms. Diagnosis, echo is great in diagnosing these tumors, as you can see on the right. You could also use CMR. And the treatment is surgical resection. And, unlike the primary malignant tumors, which I just mentioned, surgical resection is pretty successful in these types of tumors with the annual mortality rate of less than 5%. And once the patient has resection, they will likely not need another resection. Only about 2 to 5% of patients who have their myxoma resected actually have recurrence of the myxoma. So pretty successful treatment option. I would be remiss to not mention this, which we will likely not see in our clinical practice, but might be tested upon in the boards. Myxoma have been associated with this inherited genetic disorder called Carney complex, which is an autosomal dominant disorder and characterized by intracardiac and extracardiac myxomas. And quite often, these patients will present with lentigines and blue neve in areas that are not exposed in the sun. And those who have this condition normally have endocrine disorders like thyroid disorders, and they may even have breast and testicular masses. So something we may not see in clinic, but something you might certainly be tested on. Papillary fibroblastomas are currently the second most common benign tumor. However, the incidence of these tumors are growing more and more rapidly. So I could see a future in which this overtakes myxomas as the most common benign tumor. And it's because we're getting better in echocardiography with TEs and surface echoes. So we're seeing these types of tumors more and more frequent. And these tumors are an avascular tissue consisting of elastin, collagen, connective tissue, and they're surrounded by a single layer of endothelial cells. And grossly, what I've seen that these tumors have been described as sea anemone, with a pedunculated stalk and kind of this filamentous arms extending out. Um, and they have a predilection, like I mentioned earlier, for heart valves. The aortic valve is the most common, then the mitral valve, and then they could also occur less commonly in right-sided valves like the tricuspid and pulmonic. But 22% of these benign tumors actually do not occur on valves, and they can occur on any endothelialized surface in the heart. So there have been reports of these tumors actually occurring on pacemaker devices, on leads, ICD leads, or pacemaker leads. They are associated with, there seems to be an association with prior cardiac injury. So patients with hypertrophic cardiomyopathy or previous chest radiation or prior cardiac surgery seem to be at increased risk for these tumors. And really, the diagnosis is through echocardiography, and they usually appear as a pedunculated mass on a valve with a shimmering edge. Transesophageal echocardiograms, as you may imagine, are especially good at diagnosing these and sizing these up because of how these tumors usually present on the left-sided heart valves. Now, these types of tumors, there's a high risk of embolization. In one case series, 30% of patients with these tumors actually presented with stroke. And so it's thought that there could be microthrombi that are forming in these filamentous arms, or that these tumors, sometimes when they're big and highly mobile, they themselves can break off and embolize. And so the treatment really is surgery. And when you find these, surgery is a preferred modality of treatment. It's been estimated in some series that the risk of stroke in patients with these tumors are about 3.5 times that of the general population. But after surgery, the risk of stroke kind of goes back down to the general population. So surgery is kind of the preferred modality in treating these tumors. And one thing of note, that we should be mindful of telling our surgeons is that 20% of these tumors has manifestations, multiple manifestations throughout the heart. So it's not just a single fibroelastoma, but there could be several. If surgery is not a viable option, in my research, I saw that some patients are treated with anticoagulation or antiplatelets to reduce the risk of embolization. And I've also seen some suggestion that if these papillary fibroelastomas are not mobile, and if they're really, really small, less than 1 centimeter, you can kind of monitor them. So those are kind of the treatment options for these benign tumors. Fibromas, these occur mostly in children, but they can also occur in adults. These are tumors of fibrous tissue, fibrous connective tissue. And like I mentioned earlier, they have a predilection for the ventricular walls. So they're well demarcated masses in the ventricular septum, apex, and free wall, and they occur more on the left and the right. And as a result, you actually see a lot of cardiac arrhythmias because of these tumors. You could also see a lot of conduction abnormalities because of these tumors. And these tumors also have a tendency to grow from the wall into the cavity. So they can also cause obstruction of blood flow. So they can cause heart failure symptoms. Because these are infiltrated tumors that are in the wall, CMR is actually the best modality of diagnosis. And when these tumors are found, really like the other tumors I just mentioned, the definitive therapy is surgery if minimal. Lipomas are another benign tumor. Like fibromas, they are more rare than the papillary fibroelastoma that I mentioned, the myxoma. And they're comprised of mostly adipose cells. They occur mostly in the subendocardial areas of the ventricular walls, but they could also occur in the mid-myocardium and the subepicardial walls. And they could also occur in valvular regions. So because of this, they cause symptoms of infiltration, so conduction abnormalities, arrhythmias, and they could also cause obstructive symptoms like heart failure. And this image on the right, it's actually interesting. When I was reading this case report, that stalk you see where the arrow was pointing to was infiltrating into the myocardium and was actually near the left ascending the LAD. So these tumors, the infiltrating process of these tumors can actually be highly concerning. Diagnosis is mostly made by CMR, but echocardiograms could identify these masses, especially if they're growing into the cavity. And a definitive treatment is surgery, although these are benign, because they often grow into ventricular walls and can cause conduction abnormalities and arrhythmias, and they are slow growing. It's preferred that when amenable that these tumors are taken out. These are my references, and I would like to thank you for your attention and open it up for questions and discussion.
Thanks, Nishant, for that very thorough presentation on cardiac tumors. I was wondering for the primary cardiac tumors, how you kind of, or if you came across in your review, how the management of those is going to evolve over time.
Yeah, and so I think the management, with the advent of multimodality imaging, I think we got to be more cognizant and be more readily use CMR to kind of diagnose these patients earlier, because what seems to help the patients the most is early diagnosis and early resection. So I think the management will really lie upon early diagnosis, which could be difficult, but I could see a future in which we utilize CMR much more readily when we have a suspicion of these tumors, kind of like in the case we had earlier, right? We had a pericardial effusion, we didn't know where it was from, and then we quickly utilized CMR and found this tumor. So I think quick diagnosis is how these may evolve. Unfortunately, I don't foresee any randomized controlled trials because these tumors are so rare, which kind of makes it difficult to treat.
Nishant, Robbie here. Very good review. Yeah, I mean, the one thing I would add to that is I think, as you mentioned, with the improvement in imaging, we've probably become less and less reliant on biopsies, and I
Yeah.
think there's probably more cases where we're sure enough of what the diagnosis is, without having to go in and biopsy. My question is, and I sort of half heard you say this, so I apologize if I misheard you. Did you say myxomas are the most common benign tumors, more common than papillary fibroelastomas?
So there's actually some disagreement in the literature I
Yeah.
read. It classically myxomas were, taught to us and taught to me in med school as the most common. But now, if you look at the current data, papillary fibroelastomas are the most common.
Yeah, that's what I was going to say. I mean, just based
Yeah.
on my experience reading echoes, the papillary fibro, we definitely see more papillary fibroelastomas than we see myxomas. And the other thing odd to your differential, we had an interesting case on Hearst a couple years ago. Lady came in with a large right atrial mass that we did end up having to biopsy because we weren't sure what it was. She came in with heart block and a large right
Oh, wow.
atrial mass, and ultimately had to biopsy it because imaging was inconclusive, and it was sarcoma. It was a
Yeah.
big, a large mass of sarcoma cells invading her, sort of almost filling up her right atrium. So
Yeah. Was it angiosarcoma? Do you remember? Because those have
sorry, no, cardiac sarcoid. Pardon me, I misspoke.
Oh, wow.
It was big cardiac sarcoid
Oh my gosh.
mass,
Yeah.
which is an unusual mass, but so put it down the differential diagnosis
Yeah.
list, particularly if they come in with conduction abnormalities. So
Yep. Absolutely.
Hello, Steve Clements.
Hey.
So Robbie mentioned that case. Of course, Robbie, if you remember, there were two masses, one in the upper part of the atrium, one in the lower part. They were rising in the interatrial septum, but the heart block means that they had something down at the top of their septum, as sarcoid usually likes to do. So myxomas, there has been evolution of the treatment of myxomas, and maybe years ago they used to scrape it off the wall and let it go, and then if you read about the recurrence rate of myxomas, you'll find that somebody will say there's a few percent recurrence per year. They wind up getting echoes for years, but surgeons now know that they've got to resect the area of the interatrial septum from which it arises. It usually arises from the fossa ovalis there.
Yep.
And we, of course, are finding them earlier and earlier because they're incidentally found on echo. In the past, we used to try to diagnose them with our stethoscope. And that comes all the talk about the oscillatory findings of myxoma and talk about tumor plops and all that. But nowadays we don't let them get that big, hopefully.
Yeah.
So sarcomas can mimic them because sarcomas can creep out of the pulmonary veins on the left or the right side. On the left side, they can creep down from the from the superior pulmonary, right upper pulmonary vein and grow down and have a stalk. And I've seen an example of that when they thought it was a myxoma and they jumped right in there and took it out and said, "Oop, this thing is not a myxoma, it's a sarcoma," and they resected as much as they could, and then it comes back repeatedly like that.
Yeah.
We don't have
Might
good
have been
therapy for that.
I wonder if that was a leiomyosarcoma because they have
I'm not sure that one was. It was an angry lung sarcoma.
Okay. Yeah. So secondary.
Coming from probably the pulmonary veins.
Yep.
And the classic one, of course, in the right atrium is a renal cell growing up the vena cava. So when you see a mass in the right atrium, you always have to pursue the origin, and especially looking at the inferior vena cava. If the inferior vena cava is full of tumor, then yes, it can be a renal tumor. However, it can be sarcoma coming from anywhere from the inferior vena cava to the uterus.
Yeah.
So it's a fascinating area that we still have a lot more to learn about.
Mhm.
And I would, most myxomas nowadays are discovered on echo. So, all right, thanks so much.
Yeah. And to your point, I think, I saw in one case series, myxomas, only 64% of those patients had some sort of auscultatory finding,
Yeah.
15% of which had that classic tumor plot that we are tested so often on. So
Yeah, that means they don't go through the
yeah,
mitral tricuspid annulus.
Yep.
So I've been interested also in looking at the vascular supply of myxomas, and we reported a long time ago a coronary arteriogram in myxomas, but I have yet for somebody to come to me from the cath lab and say, we found a myxoma by looking at the coronary arteriogram and seeing the tumor place and the venules there. But one day maybe that'll happen.
Yeah.
But that has a very characteristic look to it. So very good.
Nishant, there's a question in the chat about any role for radiation therapy, which I think you talked about a little bit.
Yeah, so there isn't a randomized control trial. The evidence is weak because most of it is based off case series and retrospective cohort studies. But I mentioned that trial earlier, which was a national derived from the National Cancer Database. And again, mind you, the ends were very low. So it compared those with surgical resection and those with surgical resection and adjuvant chemo or radiation therapy. So there was chemo in there as well as radiation therapy. And I think the ends of the group was like 41 individuals had surgery and adjuvant chemo and radiation, and only 29 individuals had surgery alone. So ends are very, very low. And what they found there is that there was only benefit seen in stage 3. But, I think there may be benefit in tumors like lymphomas. But really, we don't have a lot of supporting evidence. But quite often, these individuals are treated with adjuvant chemo and radiation therapy.
Well, if there aren't any more questions, I will thank Nishant for being such an excellent speaker this morning, and we will see everyone next Friday for a conference again.
The preceding program is copyrighted by Emory University.